5 minutes. After others come, I'll make a few introductory remarks, just 2-3 minutes, and then we'll go ahead with the presentation. Is it okay? Shall we start from there? 5 minutes. After others come, I'll make a few introductory remarks, just 2-3 minutes.
I'm Shankar Pita. I work as an associate professor in School of Public Health at PGH Chandigarh.
I'm Priya Balasubramaniam. I'm a senior health scientist in public health information. Creator by Germany, editor of Business Healthcare in the US.
Good morning. I'm Punita Suresh. I come from Chennai. I'm working in the Banyan, and this is from the disability sector.
Morning, I'm Dr. Narendra. I'm an orthopedic surgeon and the former director of the Samson Institute of Science.
Namaskar, I'm Surendra Srivastava, LokSatta. Good morning, Srinath Reddy, the Public Health Foundation of India.
I'm Jayaprakash Narayan, General Secretary of the Foundation of Democratic Reforms.
Good morning. Good morning. My name is Venkatram. I'm at the WHO.
Good morning, everybody. I'm Sivaram Krishna Padu, consultant orthopedic surgeon in London.
Good morning, everybody. I'm Dr. Praveen Kalimat. I am a general practitioner working in the NHS in Leeds.
Sujata Rao, former Secretary Health Council.
I'm Viveka Rai. I'm also an IAS officer. I've worked for long years in the health system.
Just by way of introduction, both Siva and Praveen, they have specially come for this at their own cost, all the way from the UK, just to participate here and assist us, because they are the ones who worked very hard to try and see how best something similar to NHS of Britain, but from Indian conditions, could be approached in a very innovative way, given their understanding of Indian conditions and their practice. We're particularly grateful to them for that time, energy, and sacrifice. So So it looks like we still have 20 minutes. Go ahead, Fatima, please give names. Please come forward. Your introductions, if you could kindly.
Hi, I'm Dr. Lukas and I'm part of the PDD Health Practice, Associate Director.
Dr.
Utkarsh.
Utkarsh. Okay.
I'm Priyanka Sisa. I also work at the World Health Organization.
Fatima.
Hello, I'm Nisar Fatima. I'm from the FDR research team.
Hi, I'm Magesh from Policy Research Team.
Hi everyone, this is Surya, with Foundation for Democratic Reforms.
I think we'll start off. I'll start off with a few words of introduction, then I'll request Dr. Srinath to make a few preliminary comments. Friends, all of us around this table are the converted. I think there's not one person here who is not committed to publicly funded quality healthcare accessible to most Indians, if not all Indians. But if you preach to the converted, that does not help. So this roundtable is a very focused and purposive one. This is not about expression of our angst or description of our conditions, except to the extent that it will facilitate development of a better model and our efforts to make that happen. We have three unless there is a compelling economic logic. So that's why I'm deliberately setting the bar high. Otherwise, the moral argument is very clear. Emotional argument is very clear, but we have to make a compelling economic argument, a case that cannot be easily resisted. Two, to come up with, there are many experts here who worked for a long time in this sector. They come up with terrific models and insights over a period of time. Now is the time to synthesize. There's nothing very original, but we have to synthesize, and together we have to come up with some model which meets at least three standards. A, it is feasible, politically, administratively, logistically feasible. B, it is effective in delivering the outcomes that we all seek. C, it is affordable to the country. Now, saying that UK spends 8% GDP, US spends 8% from public exchequer, some other countries spends 5%. All this is nice, but that doesn't take us anywhere. We have a certain situation in India, therefore, unless it is feasible, effective, and affordable, given the specific Indian context with all our strengths and weaknesses, the model will go nowhere. Ultimately, we must achieve a realistic outcome. If we're aiming at 100 today, at least 70, 80 must be achievable in the next 1 or 2 years. And the policymakers and the political executive and the parties must come on board. And unless we work on that assumption, this will be a futile exercise. Therefore, it has to be very focused thing. A certain model has been attempted on the basis of synthesis of all the existing literature and efforts and expert committee reports. This is not written in stone, which really works everywhere. India is a diverse country, therefore all we can look at is some generic approach based on available numbers. Even numbers are very confusing. All kinds of data problems in this country, we all recognize that. So we make some assumptions, we make some guesswork, we have some ballpark numbers, hoping that they're not too far wrong, maybe 20, 30% wrong, but not wrong by an order of magnitude. But we have to come up with a model we all can broadly live with, and we'll keep on improvising the model. Even as the government starts implementing it, if they do implement it, I'm sure they'll find many more better approaches with more experts, more experienced practitioners coming to the fore. And C, we have to start a process of networking informally, create some kind of a universal healthcare network. We have to make this happen, and therefore that effort is equally important. Therefore, these are the three specific outcomes we see. Let me recap. One is to make a compelling economic case which cannot be resisted by any reasonable organ of state or functionary in government or political parties, and also that appeals to the country at large, and to come up with a viable, with a feasible, with an effective and affordable model, and to have some kind of an action plan about the strategy to make this happen by pursuing the matter. Already we have a meet 5th day after tomorrow with Niti Aayog. They asked for a presentation on this. It's good that they asked on 25th, so that we take the feedback of this team today and incorporate that. As nothing is written in stone, but that's the first step. But this is a very small first step. There's a lot more to happen, and we really have to together pursue this. We're already very late as a country. We all know that. And at least now in the next few years, make this happen. This is one of the greatest accomplishments. And all of you. In summertime, at enormous personal privation, people have taken the time off on a Saturday to be here for a whole day. And that means a lot. And I'm sure more people will join. And I'm particularly thankful to both Shiva and Praveen for that enormous time energy and sacrifice. Now on to Dr. Srinath.
Very much, Dr. Prakash Narayan. Basically, as Dr. Narayan has said, there is an opportunity now to try and provide some inputs to policy through a wider public discourse, which can provide information as well as attempt to influence that policy. We have the legacy of multiple systems created by design but emerged by default. And we now need to deal with that legacy in order to try and remedy the situation in terms of fixing some of the faults and trying to create a new structure without necessarily having to dismantle everything, because that's not really possible. And how do we do that best in a framework of universal coverage which provides assured access and affordability to all, with that particular emphasis on ensuring financial protection for the poor and the near poor and the middle class as well. And so in a situation where, as well as the ground reality, state-specific contextual modifications, how do we still retain the element of portability of a system across the country? These are going to be some of the challenges. But a wider public debate is important. Almost as Dr. Prakash Narayan said, almost everybody is agreed that universal health coverage is a good idea, whose time has come not merely because it's part of the SDGs, but because it is a compelling need for India. But the roads to universal health coverage are fiercely debated. Many people have different ideas, different models, and even what is meant by universal health coverage is also debated by different people who have different definitions to it. But it's important that we get some clarity, and the only way we can get some clarity and later on consensus is by wider and where different opinions can actually be aired, and later on we may be able to get some convergent consensus. And that's why this particular consultation is of great value in providing platform for that kind of debate. And for chairing the first session, we have Dr. Hank Beckham, who is the WHO representative to India. Dr. Beckham is ideally placed, not merely because he represents WHO, because in his own professional experience, he, at the time, when the Chinese health reforms were being and influenced some of that process through his own contributions. He also served at the Western Pacific office of WHO, where he was a fairly engaged witness to the changes that were taking place in terms of universal health coverage and health reforms in countries like Vietnam and South Korea. And then he also served in Egypt as country representative, and he has come here. And since Dr. Prakash Narayan has very clearly emphasized the number one priority of this consultation is to make an economic case. In his academic background too, Dr. Becker's training in economics, I think there is no better person from point of view of his experience as well as his overall expertise to chair the opening session. Over to you, Dr. Becker.
One logistical issue. Each of you is given the schedule today and also issues to be resolved. This is not exhaustive or comprehensive, but a general outline so that we actually focus. In each session, we expect to try and see how many of these things can be covered. The first session has no issues, the overall presentation, but the next one onwards, primary and family health, we will take up each segment of this. The idea is that we will, as far as practicable, come up with some coherent answers. Some of the questions are immediate answers, some may have maybe some divestitive opinion. But my request is let us try and get answers to these and other possible questions so that the model will improve. That's a specific question. Dr. Becker.
Thank you very much, and thank you also for your kind introduction. Good morning, everybody. It's really a pleasure to be here, and I think the emphasis on the consultation part, I think I can't agree more from how important it is that we discuss these matters. I'm 5 months old in the country, still learning. But for sure, one of the things that has been lacking so far, in my view, and I think I have expressed myself sometimes in meetings like this and sometimes in opinion pieces and the like, is indeed to think about from where India should be in 2030. A vision for how the system should start looking like. And especially in a country like India, accepting that states have the main responsibility in health. If you do not have an idea for where you will go, it becomes chaos. So in that sense, to have a discussion over here, to have a sense of directions, if this is this direction that we need to be going, it's very important. I'll even share with you something, but you should probably not to say it to anybody else. When I started on my first discussion with government officials, and I was trying to have a debate about vision. Many of them said, I don't have that time frame. My time frame is 2 to 5 years maximum. And then I said, look, but if you have something like the health sector, which is very complex, there is no way that you can achieve things within 2 or 5 years. Of course, you can achieve things, but if you it's far beyond 2 or 5 years. But I have also to give some credit for the whole process. What happened is then 2 months later, and I started discussing with the same official, actually, he called me. I'm already revealing the gender. And then what happened is the Prime Minister's office started asking questions from guys, where are you going? Where does it all end up? What would you now like to do from doing this? That how does it relate to what elections, etc. I was very encouraged by this. And I think we shared also with also some discussions about this, and we felt from, look, I think there is now, it's the right time to start discussing about where to go. It is true that in this whole process, and the chair of what I need to be careful you might expect me to say a lot of issues already before anybody starts talking. I think in some issues that you raise three issues, some issues will be very clear. Economic argument, I think it will be something just the arguments that is not only about India, that's any country investing in health, investing in wealth. But again, let's not go into details on this one, the arguments will come. But I think it's also true from having worked in several countries, there's one thing where I don't know. You start from where you are. You cannot start jumping over the realities in the country. And I think there is an issue which is very not only about realities, it's also about people. You came up with initiatives. They might not be perfect, we should better start working with it, because these are the people who will be taking the matter forward, ignoring from what has already been done, ignoring that many things start also from a good heart, and coming up with something completely new. We need to be careful. So, but having said so, that should not stop us taking forward you need to be able to. I think these are two different issues. I'm also a strong believer from that's in my work indeed. I think so. I think you're also referring to this from not in China, but I would also in 37 other countries. And we have always two issues. One, we said you need a vision where you would like to go. And then you start defining what you're going to do the next 3 to 5 years. Because even when your vision is very clear and everybody agrees, nobody can make a big step at once. You will fall, things will go bad. But then you start defining from what you know where your journey is going. You start defining how your first steps should look like, and also be very accountable. But let me not say too much to share this very much. But I'm very much looking forward for the discussion. And almost like I said, over to people who are going to present. And then once we can take this conclusion so far from the NHS is also close to my heart, my research. I've studied also in the School of Economics, and for sure the NHS was a very special day. Very much looking forward to it.
Everybody has this book. If you don't have copies, read them. This is somewhat dated already. This book is what we have and the hard copy was sent. Will somebody make sure that those who need them have copies? But this is already dated. While my fit is the same, but the structure is changed. Comment like what I myself managed to myself. And also some of the numbers, even in the last 15-20 minutes, get some of the numbers. Everything is ballpark. Therefore, these numbers keep changing, but we're trying to get the best estimate or guesstimate at the point of time. The actual model part, I would request take you through some of these slides. Sure, as far as practical, I would request you to stick to this because the numbers are based on this. Then you come with the feedbacks. Okay, I leave it. What am I start. So first, the markets, you almost some pictures are nice to make it look more attractive. But is it difficult to follow? Can you allow the size or something? Is it about the size? Next one. Still true. You might allow the size. But this does not require much elaboration. This team knows everything small for completion's sake. Next slide, please. This is the some of the accomplishments on failings in the Millennium Development Goals. Again, right one is the stunting of growth. Next one, please. But we're all familiar, I think it would be worth to spend a half a minute on this. If you see on the x-axis GDP per capita purchasing power terms, and the axis is one indicator, obviously, or recognizes one of the perhaps sensitive indicators related to us, the state of health in the country. The tendency all over the world is as per capita income grows, the IMR comes down. And we have taken only the emerging economies and poorer countries, not the richer countries. You can see India is an actual outlier. Our health indicators, even in terms of related to our poverty level or income level, are simply falling back. We're absolutely the worst. You can see that. If you see both income X and Y axis, both obviously not acceptable. I think somebody in government must really start understanding this. Philippines, Vietnam, and Kyrgyzstan, Nepal, Bangladesh, I keep telling people to take this path first in education. They are slightly worse than us. In PISA outcomes, Kyrgyzstan is very much in terms of, it's not good, but they're a poor country, much lower income per capita. Next one, please. Next slide. Okay, this is hard to beat. Just a big picture. 1.2 million children under 5 they died in the year 2015, around 1.2 million children. 9.7 million people. Can you read that?
Total annual cases of 9.7 million malaria infections, 2.5 million new cases of tuberculosis in 2015. Out-of-pocket expenditure for health forces 63 million people below the poverty line.
This number, even in this presentation, we used a number varying from 55 million to 63 million. Each source is giving a different number, but they're roughly comparable numbers. Therefore, please do not hold us to ransom or count on the specific number. Something like 50 to 60 million people falling below poverty on account of expenditure related to health or on account of health and therefore reduced income. That's the broader picture. We're not accurate assessment.
28% of deaths are caused by mostly preventable communicable diseases and maternal, perinatal, and nutritional diseases. Only 65.2% of the children aged between 1 to 2 years are fully immunized.
Everything is sourced to something or other. A very credible document. None of this is properly had in the government documents or international agencies, WHO, sometimes even consultancy, globally recognized consensus organizations, but everything is sourced. Therefore, there is some basis for these numbers. When there is extreme accuracy in the country, where we have some basis, Next. NCD, which including me, many healthcare experts, for a long time have not really bothered much about viral disease related NCDs. Should be there. I think got it from KPMG, right?
Yeah.
KPMG. Not the right one, so yeah.
The left one is occurred in 2005. Right is expected in 2030.
Okay. The blue is current, 10 years before. 2030, the year Dr. Becker talked about. Everywhere you can see an expected increase in disease burden, etc. Next. Again, these are very well known, these challenges, but will you please read them so that we can focus?
First one is low public health expenditure share, high out-of-pocket health expenditure, inefficient public-private partnerships, lack of accountability in public health care, unaffordable family care, doctors' accessibility in rural healthcare, decline in family care over specialization, which leads to over specialization, alternative systems integration.
Okay, next please. Just to show that this is government defined budget allocation. It's a voluntary 30,000 crore plus as the latest number is 38,000 crore. I don't know how much actually we expect. So the detail simply glosses over the picture. There's very clear. That's all. I don't think we need to go into the table. Next please. This is total health expenditure. We've taken only some of the comparable economies. China perhaps not really comparable, but not the rich countries. This is the total health expenditure society related to GDP. You can see from top view, the colors are incomprehensible to us. From top view, the big thick dotted line is India. 54% numbers vary from 4% to 4.7%. Exact number we don't know. Public plus private together. The rest of it from top right top, will you please give us the names of the countries?
The first country on the right top is Vietnam, then China, Thailand, Philippines, India, Sri Lanka, and Indonesia.
This is the total health expenditure. Next one, please. This is public health expenditure. Thailand ranks the highest in Asia. Among these countries, 3.7% of GDP is public expenditure. Then China, then Vietnam. Other countries are roughly, India still is somewhere at the bottom. Other countries not much better. Next one, please. This is health expenditure in purchasing power parity terms. Again, Thailand ranks the highest. China ranks next. Other countries are all roughly at the same level. Worst, of course, is India. Select countries. The left bar in each country is the share of the budget. The right yellow bar is the share of the GDP, health expenditure, public health expenditure. South Africa, 14% of the budget, 4.33% of the GDP. Brazil, 6.93% of the budget. That seems a little wrong. I can't believe that the government budget in Brazil would be 2/3 of the GDP. There's something wrong with Brazil. We have to verify that number. I'm not sure. Russia, 8.42% of the budget to 3.15% of the. It's possible they were taking federal budget, but total health expenditure for the country. So there's some discrepancy in numbers. Bangladesh, 7.84% of the budget, 1.31% of the GDP. India, 4.55% of the budget, 1.28% of the GDP. Indonesia, 6.68% versus 1.2%. And China, 12.63, 3.11. Almost everywhere India ranks. Next. State. In most countries, if you notice the right graph, USA about 50%, Australia about 50%, and in federal countries about 40%, Brazil about 40%. India is somewhere about 20%. The total public health expenditure, the federal government's expenditure in India. And this is after the successive governments have promised that they will enhance the expenditure, public expenditure. I think UPA talked about increasing from 1% to 2 to 3. They can give exact number. This government probably talked about 2% to about, overall government policy is yet still adaptables. So the actual truth is declining. The share of federal expenditure. We'll take only births and deaths because this is the most preliminary record, let alone the most sophisticated national health register and so on and so forth. The picture is pretty grim, with the exception of Sikkim, where the deaths are well recorded, not the births. I think 100% deaths are recorded in Sikkim. Otherwise, it's still appallingly bad. 50-60% recording of births and deaths. It shows that even the basic record keeping and understanding what's happened to the population, we have no clue, except some sample surveys and health records. Well, many interventions we have focused on that. I think there's not enough debate on this issue of health records as an integral part of improving the health system. This indicates these numbers are going to shortfalls. The BHCs and CHCs. This is more of a normative thing. But frankly, in reality, even if they do exist on paper, in most cases, while we become monitors, they're really inconsequential. So this is more for a general picture rather than very detailed analysis. Next, please. This is to be a general picture of hospitalization, public and private. It appears that about 35 per 1,000 population is hospitalized in India during the year. How long we don't have to get up. On average must be 6 or 7 days. That's the common pattern of surgery in the country. Urban areas 44 per 1,000 population. So 35 to 40 per 1,000 population are hospitalized on that means there are actually patients. It's an important number to understand what secondary patient we have. That's very important. Next.
100% dependent on and the reasons why not is undeveloped. Again, everybody understands what's these numbers. Numbers seem to be different state to state, but all of the picture is there is significant amount of high cost one all the profit by people. And the left side was brown just the numbers. State wise how much money they're spending by hospitalization. The right side, the same state. You have percentage missing public hospitals, private hospitals. The picture is very balanced. Expenditure is very out of pocket these numbers of the national health policy. I'm not sure about the accuracy of the numbers because earlier studies, etc., they show different numbers because this is a government document. We put there 68% of the expenditure in rural areas and 75% of the areas for savings. The rest is borrowing, maybe selling assets, whatever. The rest. And the numbers were much more brief. So I don't really know how much is what. There is so much what is what is next. We all know about the impact of the public expenditure. We put just question to the hospital side. The left side shows the income patients. The right side shows the 2014. So the current picture for patients is 854 rupees for those who are the government hospitals. And 788 rupees for those who are the private hospitals. And hospitalization is 6,180 in public hospitals and 25,850 in private hospitals. So, okay, this is pretty well on everybody. That's to complete this. Next. Again, the national protection of the pockets and the share there is a top of the countries where they are Asian countries, etc. Indonesia. The next is China, and the last one is Thailand. So Thailand again is the best protection based on small project partners. I think once on public expenditure, you can see evaluation. This again very well known, but just to emphasize this point, making the comment that officially the policy exists that priority of what's happening. So we thought we'd actually put some of these pictures and take the actual numbers in terms of some of the drugs, generic drugs, which should be generic drugs. Even if you professional company. It's nice, looks like the updates. I believe that this is the cost of production. Minus that. Because the cost of sale is 60,000, it's 110 times. It's 90 times. Production. 2 lakh rupees is the same price. But it is 1,000 times.
then next one. This is the markup is 140 times. 1,100 rupees is the cost of production. This market sales price is 1,50,000 rupees. Then 190 times. 550 rupees is the cost of production. 106,000 rupees is the sale price. Next one, cash. This is 21 rupees is the cost of production. Cash is the principal. So, next slide. The allocation is 0.1% of GDP. That is out of the total public expenditure in June 1.2 to 1.3. We are spending only about 7% on drugs. Whereas presently, 58% is covered some areas for the optimal budgets and regulations. The large measure, because of its the total medical expenditure from 72% to 68% of the areas. That is the cost of buying medicine.